indications for oxygen and goal of oxygen therapy. You understand now the peripheral chemoreceptors and the central chemoreceptors, and it's important that you know when the peripheral chemoreceptors kick in that these four things happen. Very, very important. You know that. So let's move on. Still student learning outcome number 15. Why do we give oxygen? What's the goal? What do we want to achieve? Well, number one, if the indication is hypoxia or hypoxemia, the goal is to correct it. Now, the goal is to correct it, and when I say correct, it doesn't always mean that the PO2 is going to be back to 80 to 100, like your COPD patient, because they breathe off their hypoxic drive, they can never have a PO2 of 80. So when we're administering oxygen, for most patients, if they don't have chronic conditions, when we give oxygen, it'll raise their PO2 back to normal. But some patients, normal PO2 for them, particularly a CO2 retainer, just may be 68. That's just normal for them, and because they're chronically hypoxemic. So when we give oxygen, we're giving it to correct the tissue hypoxia and or hypoxemia. The second indication was an increased work of breathing, so we give it to decrease the work of breathing, alleviating a shortness of breath. And then thirdly, we want to decrease the work of the myocardium, that ventricle. So if the cardiac output is increased, we want to decrease it to quit overworking the heart. So the indications are a problem, and this is what we want to do. Now this is just for the oxygen solely. If the patient is asthmatic, we need to give the bronchodilator. If the patient needs other drugs or therapy, they need that as well. So oxygen is not always the answer to every problem. However, we would never deprive a patient of oxygen. Okay. So oxygen solely may not improve the problem. Everybody understand that? All right, but these are the goals. WOB. Work of breathing. Okay, student learning outcome number 16, meaning this follows your syllabus, whatever that statement is. So supplemental oxygen can be delivered from 22% to 100%. The 22% comes because room air is what? 21%. And we know the FDA regulates oxygen, and the purity is supposed to be 99.5%. So overall, we're believing if we give oxygen at a liter flow of 15 liters per minute, full blast from a flow meter, we're providing 100% oxygen. So when we talk about supplemental oxygen, we're not talking about room air. We're giving them additional oxygen to achieve the 3 goals on the previous PowerPoint slide, right? So that FiO2 can range anywhere from 22 to 100%. It depends upon the device that we're going to use. And I know Ms. Pope is ahead of me, but I have more to explain in theory. Okay, so the first type, when we use oxygen, there's 2 types of systems. It's a low gas flow system, and it's a high gas flow system. And there are different apparatuses that we use for low gas flow, and there's different apparatuses that we use for high gas flow. Now when I say low gas flow, I'm talking about flow, liters per minute. And when I say high gas flow, I am still inferring liters per minute. I'm not referring to FiO2. Everybody understand that?
Yes.
All right. All right. Low gas flow systems are those methods, apparatuses, we'll get to them, used to deliver oxygen to the patient. However, when we administer a low gas flow system, The number one criteria is the patient must be breathing spontaneously. So that means if a person is apneic, we don't put them on a low gas flow system, because the number one requirement, regardless of what their PO2 is, they've got to be breathing spontaneously. Okay? If they're not breathing spontaneously, then we do something else. So a low gas flow system, I probably should have this in bold, but you can underline it in your PowerPoint. The patient is also ventilating spontaneously. We're ventilating spontaneously right now. We're spontaneously breathing, meaning we don't have to think about it. So that's the number one criteria for a low gas flow system. And I'm going to give you a hint. During your lab practicum, you're going to do an oral lab practicum, and whether it'll be 3 or 4 of us, and if whomever asks you about a low gas flow system, even before you start defining what those pieces are, make sure you tell whomever is asking you that a low gas flow system requires that the patient is breathing spontaneously. Okay? All right. So part of the total flow of the gas to the patient is a combination of the supplemental oxygen that we're administering, but it's also from the room air that they're inhaling. Does that make sense?
Yeah.
If they're breathing spontaneously, they're going to get a flow that we use or we set up, but they're also going to breathe in some room air. And the third bullet says, using a low gas flow system, the FiO2 is variable, meaning that we can't deliver a specific FiO2. The FiO2 is going to be variable depending on the amount of air the patient inhales. Variable. We can have 2 patients in the same room, the same age, the same height, the same weight, the same sex, the same race, and on the same oxygen device. But how much oxygen they receive would depend upon how well or how poor they ventilate. So let's use an example. We have one patient with all that criteria, all those factors that I just said. One patient has a respiratory rate of 12 breaths per minute, and another one, bed B, has a respiratory rate of 18 breaths per minute. Okay? The patient that has 12 breaths per minute will probably get more oxygen being delivered to them as opposed to the one with 18 breaths per minute, because the patient with 18 breaths per minute is going to inhale more room air. And as you inhale more room air, the FiO2 decreases. Does that make sense? The more room air you inhale, the FiO2 decreases. So that's what I have here. The more room air inhaled, the lower the FiO2. What's lowering it? The room air that you're inhaling. We know the oxygen source coming from the tank or the wall is 100%, but what lowers it? How much room air the patient takes in. So if you will, it's kind of like, and I don't want to be negative, but it's kind of like when we spontaneously breathe, it dilutes the oxygen from 100%. And that's okay, because everybody doesn't need 100% oxygen. Okay? And so the next one says the less room air inhaled, the higher the FiO2. So let's go back to our same patients, same weight, race, sex, and all that. One is at 12 breaths per minute, one is at 18 breaths per minute. The one who is breathing at 18 breaths per minute is going to inhale more room air, and so that's going to lower their FiO2. And the one who is breathing at 12 breaths per minute is going to inhale less room air, so possibly the higher FiO2. Okay. So with a low gas flow system, the FiO2 is variable. It's going to be within a range, but it's variable. And what is it based upon? How how well the patient is ventilating. That's why a patient must be spontaneously breathing. Got it? Any questions? It will make a little bit more sense to you once we go through the particulars. You had a question, Kyle?
Yeah, if they're on a rebreather, 100% non-rebreather rather, then that would be, would that be void because they're not breathing, they're not getting any ambient air at all. It's just all coming out of the tank, right?
No, sir. A non-rebreather is a low gas flow system.
So they're getting
So they can
outside
still,
air.
it's no guarantee that they're getting 100%. We would like to hope that they do, but not necessarily. It's a low gas flow system. They must be breathing spontaneously.
Okay.
They'll get a higher FiO2, but it doesn't have to, it could be anywhere between, it could be 75%. We won't know that unless we analyze it, but nope. Only high gas flow systems will guarantee specific FiO2. Oh. Okay, student learning outcome 21. Turn to page 911. And I've gone through the indications, but that's where I got the indications from. And I've gone through the goals, and that's where I got the goals from. Now look at the contraindications. This is according to the American Association for Respiratory Care. Do I have the right pages on there?
Yeah.
Yeah, all right. Look at the contraindications. Kelly, would you read the contraindications, please?
Yes.
One by one.
With a few exceptions, no specific contraindications to O2 therapy exist when indications are present.
Okay.
Certain delivery devices are contraindicated, such as nasal cannulas and nasopharyngeal catheters in pediatric and neonatal patients with nasal obstruction.
Okay. Is that it?
Not under
yeah.
contraindications.
On the contraindications, okay. So precautions and or complications. Okay, this is depression of ventilation. Okay, I've explained this, but this is peripheral chemoreceptors. This is a precaution. You got a CO2 retainer. And you want to give them oxygen. We can't put them on a non-rebreather, or we don't want to give them a high FiO2. Because if we give them a high FiO2, it'll knock out their hypoxic drive, right?
Yes.
Okay, so here's the rule. If a PaO2 is increased, but the patient is breathing off or his or her hypoxic drive, it will depress ventilation. And I don't know if it's in your text, but I know it's somewhere, but I don't know if it's right here. It's called oxygen-induced hypoventilation. Oxygen-induced hypoventilation. O2-induced hypoventilation. And that's only for a person breathing off of their hypoxic drive. So what am I saying? If we give them too much oxygen, which is oxygen-induced, they're going to hypoventilate. It's going to make their CO2 go up and up and up and up and up because they're CO2 retainers. Does that make sense? Everybody understand that? So if we give them too much oxygen and all they have are their peripheral chemoreceptors, it's going to slow them down from breathing. And as they slow down, they hypoventilate and they retain more CO2. So too much oxygen will depress ventilation, and consequently, they're going to hypoventilate. And from an acid-base perspective, you understand that's hypercapnia or respiratory acidosis, yes? Everybody with me? Then they're going to become lethargic. And lethargic means that they're going to appear, when you walk in the room, they're going to appear like they're sleeping. But they're not sleeping. If you talk to them or if you call them, they'll open their eyes and they'll respond. But they now have a buildup of CO2. And remember, those hydrogen ions are no longer responding, and the central chemoreceptors are no longer responding. So they're going to seem like they're real sleepy, they'll open their eyes, and they'll talk to you. But as soon as you stop talking to them, they'll close their eyes and it'll seem like they're asleep, but the CO2 is building and building. So they become lethargic, and then we call it CO2 somnolence, where it appears it appears again that they're sleeping, but this is oxygen induced, is too much. And then they have CO2 narcosis. Now the CO2 has become toxic, and it's steadily depressing ventilation, because we've given them too much oxygen, and consequently it causes apnea. They'll eventually stop breathing and have a respiratory arrest. Yes?
Can you explain CO2 somnolence?
CO2 somnolence is the next step after being lethargic or lethargy.
So it appears they're sleeping.
It appears that they're sleeping, but if you talk to them, they'll respond. CO2 is building up. And so what am I talking about? If we get a blood gas, I'm talking about CO2s in the 80s, the 90s. Sometime we've seen it. One of the senior students had a patient, their CO2 was 115. And I said, that's CO2 narcosis, because they had given this patient, it was scary, but they were telling me therapists on the night shift didn't check and had put the patient on a non-rebreathing mask. And the CO2 built up, and the patient, by the time they got to the patient, I think about 7:15 that morning, they were in CO2 narcosis. And the PCO2 was 115, and the PO2 had dropped to about 30.
Wow.
So unfortunately, on that patient's expense, the students got a chance to see, I guess, hypoxic drive being knocked out. Okay, so this is why you don't want to give too much oxygen. You cannot give too much oxygen to a CO2 retainer. Now, if a person's not a CO2 retainer, other things are going to happen. But you got to remember, oxygen is a drug, right? So too much is just as bad as not enough. But for a CO2 retainer, this is dangerous, and therapists understand this. We cannot knock out the patient's hypoxic drive. So the more oxygen you give them, yeah, the PO2 is going to go up, but it's going to raise the CO2. And that's not good, because the peripheral chemoreceptors is all they have to ventilate. And if the peripheral chemoreceptors get above 60, they're going to shut down. And all the patient has now is to hypoventilate. And so we'll see lousy PCO2s in the 80s and 90s, and some get up in the hundreds, 110. The blood is not red, the blood is black, because it has no oxygen in it. It's full of CO2. Make sense? Mm-hmm. Okay. So with the CO2 retainer, I'm getting ahead of myself, but with the CO2 retainer, we can give them a nasal cannula at 1 or 2 liters per minute, no more. 1 to 2 liters per minute. Nasal cannula is N/C. I never write it out. 1 to 2 liters per minute, no more. CO2 retainer. You don't put them on a simple mask. You don't put them on partial rebreathing masks. These are low gas flow systems. I know I haven't gotten there. We don't put them on non-rebreathers. That is a no-no. That's a precaution. Nasal cannula, 1 to 2 liters per minute. We don't put them on other low gas flow systems. Everybody understand that? Why? You'll knock out their hypoxic drive. How do you know that? Because the FiO2 is variable. We won't know what they're getting. But we do know that they'll probably get too much and will cause them to have a respiratory arrest. Okay? What patients specifically? Not all COPD patients, CO2 retainers. CO2 retainers are only breathing off their hypoxic drive or their peripheral chemoreceptors. Got that? Central chemoreceptors knocked out, gone forever and a day. So that's all they have. And we give them too much oxygen, we kill them. So oxygen is really toxic to their body. So this is a case where we do give oxygen, but it will never, we never, ever, ever expect the PO2 of a CO2 retainer to be 80 to 100 millimeters of mercury. You can forget it. It's too much damage that's been done to the lungs. Everybody understand that? Any questions? Yes, ma'am.
So with the CO2 retainer, when we're looking at blood gases, and if they're in the hospital, we want to see that be like in the 60% or below 60.
See what?
Like the PaCO2.
It depends. Some of them, they may come in and what may be normal for them is about 65.
Okay.
That may be normal for them. But if they're coming in an acute exacerbation of whatever, PO2 could be well 35, 40.
You said CO2 retainers, if they're when they get to that level, they're always leaving their perpetual chemoreceptors is what they're breathing off of at that point. They're not the other ones.
When they're diagnosed as CO2 retainers, that's all they have.
Okay, so everything else is gone. That's it.
Central chemoreceptors are knocked out. Okay, that's it. And that, believe it or not, will be determined by PFTs. They have to see a pulmonologist. They'll do the PFTs, and a pulmonologist will say stage 1, stage 2, stage 3, stage 4. Stage 3 and 4 of COPD are your CO2 retainers.
Because there's no correcting it. Once you get, you're progressive, you're done. You're over.
You're done.
Okay.
Yes. Even stage 1 or 2 is done. However, if they stop smoking, they'll always be in stage 2.
Okay.
But if they continue to smoke, it may be 4 or 5 years or whatever, they'll be stage 3. They continue to smoke, it may take another 10 years, whatever, they'll be stage 4. And stage 4 is terminal. No going back. And those patients don't die from lung complications, they die from heart failure.
So then the chemosensors just keep getting weaker and weaker, right? They're just overworked to the point where they say, chuck it, done.
And that's another reason home O2, the FiO2 only goes to 40%. Because if it's a CO2 retainer, they'll knock out their own peripheral chemoreceptors by upping the oxygen. Yes.
As a non-COPD patient and a non-CO2 retainer, like let's say my PaO2 was lower than 60 and I was breathing off my hypoxic drive. Would we be able to go back on our?
Absolutely.
Okay.
Absolutely. Once the PO2 reaches 60, your peripheral chemoreceptors will shut down and you'll go back to breathing off your central chemoreceptors. Absolutely. Yeah, that's what happens. Yeah. Okay, any other questions?
So
Yes.
what stage is it where it becomes reversible? Is that just
It
one-
is, COPD is not reversible. It is not reversible. Asthma is reversible. COPD is not. Any damage done is done. Now you can stop further damage, but any damage done, even in restrictive diseases, pneumoconiosis, histoplasmosis, alomosis, done. Damage is done. Your lungs are precious and most people don't realize it. Yes, ma'am.
Is it possible for somebody who is diagnosed with COPD to remain in the rest of, like, say, they get diagnosed at stage 1, and then they progress to stage 2, but they stop, they do everything they're supposed to do? Can they sustain in stage 2 for the rest of their life?
Depends on comorbidity. I can't answer that. It depends on what else is going on in their body.
Okay.
If they don't have any renal problems, if they don't have any cardiac problems, if they don't have any hypertension, if they're not diabetic, I would say yes. But if any of those are
Just
around or
exacerbate.
manifest, probably not. Right.
They ain't gonna be running no marathons, though. It's
Absolutely not. They may not even be able to holler. So believe it or not, I'm not expecting you to know this. Some of you may choose to work in pulmonary rehab. And pulmonary rehab, in 3 months, your goal as a respiratory therapist will be for the patient to get up out of the bed, sit on the side of the bed, and walk from the bed to the door without being short of breath. That may be what you achieve in pulmonary rehab in 3 months, because you're going to teach the patient how to retrain themselves, how to rebreathe using abdominal muscles and pursed lip breathing. And that's it. That's all they have. And if they continue to sneak and smoke whenever they come in, and you do a blood gas and run it through a co-oximeter or whomever is doing it, and you see the carboxyhemoglobin or the methemoglobin is greater than 1%, you can't expect any more than that because you know they're still smoking. So once the damage is done, it's done. Central chemoreceptor activation is not reversible in COPD. In others, if we get hypoxemic, yeah, it is. But not in COPD. Hydrogen ions get tired. And so they don't respond. Like, nope, I'm not doing it anymore. You do what you want to do, and people generally choose to continue to smoke. And so that's what happens. Okay? So, I explained central peripheral chemoreceptors, so when we got here, you can understand. So this is a precaution. CO2 retainers, you can only give them a nasal cannula at 1 to 2 liters per minute. If we need an FiO2 higher than that, we don't use a low gas flow system. Now, nasal cannula, we can run it up to 6 liters per minute. You cannot put a CO2 retainer on 4 to 5, 6 liters per minute, because truly you're going to knock out their hypoxic drive, because you don't know what the FiO2 is, because it's variable. Understand me? So when we get to high gas flow systems, or Ms. Pope may get ahead of me, which is fine, when we get to high gas flow systems, we can put them on a Venturi mask, which is a high gas flow system, and we can deliver a specific FiO2. Got it?
Yeah.
All right. So here's your precaution. All right. Student learning outcome number 20, avoiding oxygen toxicity. Now this is not the CO2 retainer, this is us. We're not CO2 retainers. O2 toxicity primarily affects the lungs and central nervous system, and the higher the oxygen concentration, the more likely the damage is done. So we just don't put a patient on oxygen and leave them forever and a day. We have to monitor them. We have to see what's going on. And the whole goal of anything that we do is give it to the patient when they need it, and then when they don't need it, don't give it to them anymore. Now, we're not going to deprive anybody, but oxygen can do damage to our lungs as well. And so what it'll do for the CO2 retainer is knock out their hypoxic drive. We understand that. What it'll do for us non-CO2 retainers, if it's not monitored, too much oxygen will cause oxygen toxicity. And we don't want that either. So the effects on the central nervous system include twitching, tremors, and convulsions when breathing 100% oxygen or greater than 1 atmosphere. It's not good. And I have here, remember the central nervous system, the respiratory center, the medulla oblongata, controls ventilation and respiratory system activity. So we understand now, and these are just my terms, the lungs are mechanical, yes?
Yes.
They have to be controlled. The respiratory center located in the center of the brain, the medulla oblongata, where you've learned about the central chemoreceptors, peripheral chemoreceptors, sympathetic nervous system, parasympathetic nervous system. They're all controlling the lungs as part of telling the lungs what to do. So just to give you insight, every patient that you may deal with, their primary problem may not be pulmonary. If you have a patient that comes in with head trauma, and whatever the trauma has affected the respiratory center, you'll have them in intensive care unit on a mechanical ventilator. Lungs are fine, but the central nervous system has been compromised that sends messages through the 10th cranial nerve to control ventilation. They can't breathe. Okay? So this is why as respiratory therapists, we understand the sympathetic and the parasympathetic, the function of central chemoreceptors and peripheral chemoreceptors, because they control how we breathe. So head trauma, subarachnoid hemorrhaging, strokes, you may have these patients in neuro ICU on mechanical ventilators, and they may not be breathing, and there's nothing wrong with the lungs. Understand? All right. Okay, how do we avoid oxygen toxicity? We avoid oxygen toxicity by assessing our patients. If they no longer need oxygen, we take them off. Now, if they need it, we don't deprive them, but we take them off. A high FiO2 can be toxic to the lungs. A high FiO2 damages the lung parenchyma and causes physiological shunting. New word for you, shunting. So this means now we're doing more harm than good. We gave the patient oxygen based on an indication, right? Does that make sense?
Mm-hmm.
Yes. We want to achieve a goal. Now we've overachieved the goal, and it's doing damage to the lungs. Okay, so what this, it says physiological shunting. Shunting is, well, I'll tell you what normal is. Normal is when you have external respiration, you have the capillaries and you have the alveoli, right?
Yes.
And you have external respiration down in that respiratory zone, generation 20 through the 28th, remember that?
Yes.
Okay, you have external respiration. So basically, we can look at it. This is the second year students will tell you the detail that we go into in respiratory care. So what you actually have, you have external respiration, gas exchange between the atmosphere and the lungs. We know that's happening in the alveolar capillary bed membrane. With me?
Yes.
All right. So in the capillaries, you have blood flow. Blood flow is referred to as perfusion. Make sense? All right. Then in the alveoli, we know that the patient inhaled, and we call that ventilation, right? So in the capillaries, we can call it external respiration, or we refer to it as VQ. V is ventilation. And Q generally represents the cardiac output or blood flow. V is ventilation, and the Q represents cardiac output, or in this case, blood flow. And so right now, I'm talking at the point of an alveolar capillary bed membrane. Let's just take one little alveoli. And every little alveoli has capillary around it. The oxygen leaves the alveoli and goes into the capillary, right? And then the CO2 leaves the capillary and goes into the lung. And that's equal, or VQ mismatch. That's equal. They're equal. But what happens sometimes when we have diseases, and I'm not going into diseases, you can take asthma or COPD, whatever. We start now getting what's called VQ mismatch. It's called a VQ mismatch. And in your mind, I want you to associate a VQ mismatch with inadequate oxygenation or inadequate external respiration. Something is going on in the lungs, and external respiration is not occurring like it should.
Respiration or ventilation?
External respiration, gas exchange, is not sufficient. Something is going on in the lungs, and external respiration is not sufficient. Everybody with me?
Mm-hmm.
All right. So if external respiration is not sufficient, we have a VQ mismatch. When we're breathing good, ventilation, perfusion, external respiration are equal. But when someone develops a lung disease or receives too much oxygen, it becomes unequal, and we call it a VQ mismatch. Okay, so here we go. And a VQ mismatch, in this case, is shunting. So what do we have? We got a high FiO2. And I explained, and I wasn't expecting you to know it then, now I do. Physiologically, when we breathe, we only use that 21% oxygen, right?
Yeah.
But what else is in the air that we inhale?
Nitrogen.
That nitrogen. That nitrogen within our lungs is inert, meaning it's not involved in gas exchange, but it's there.
Yeah.
Okay? Remember, well, hope some of you, or maybe you're a parent and you did it for your child. You were learning how to ride your two-wheeler and you had training wheels. And you perhaps didn't know they were training wheels. But you had a parent, a big brother, somebody, big sister there to support you. All right. And then they took the training wheels off. Or you've seen it on TV. What's that show? My sister looks at it. It's where they sit in the videos. America, yeah. Every night, she loves animals, so every now and then she'll keep it. Look at this, and Anyway, you'll see it on there where the kids are riding their bike and they have their training wheels. Then the parent takes the training wheels off, and as long as they think that the parents are back there watching them, they can ride and they go fine. But as soon as they look back and they don't see their parents standing there, they fall. That's how nitrogen is in the lungs, even though it's not used in external respiration in the body. If we supply 100% oxygen, we wash out the nitrogen. And then the lungs look around, well, where's the nitrogen? I know I don't use you, but you're supposed to be there to support me. So the lungs will begin to collapse and close because the nitrogen is not around and the lungs don't need 100% oxygen. So when the lungs begin to collapse and close, that's called atelectasis. Collapsed lung. Alveoli close. And if they close, what does that mean?
They're not expanding.
They're not ventilating. They can't get no air through it. So here, let's go back to this. The alveoli is ventilation, right? The capillary is perfusion. Everybody understand that? The alveoli has the air in it that we inhale, inspiration. So that's part of ventilation, yes? The capillary has the blood flow going through it, and so we call that perfusion. Now, what is a shunt? I have right here. Shunting occurs in the alveolar capillary bed membrane, external respiration. A shunt is perfusion without ventilation. So what am I saying? We've given 100% oxygen, and we've caused the lungs to collapse. They close. We still have perfusion. We still have the blood flow in the capillaries coming to the lungs. But the lungs have collapsed, so there's no ventilation. And so perfusion without ventilation is called a shunt. And I'll explain what that means. Any questions on what I've said? Perfusion without ventilation. That's a shunt. Respiratory therapists, everything you learn in respiratory therapists know.
So because nitrogen is a more dense gas, what happens is that just acts as a filler to hold the lungs up while the oxygen comes in and does their job, right?
That's a good way to look at it. Yes, sir.
So if you're saying if we get too much oxygen, nitrogen can't be in there either?
Now, if we give too much oxygen, it washes out
Okay,
the nitrogen. It replaces the nitrogen.
okay.
Okay? And it's just like there's some things you don't want to substitute. You want the real thing. Okay? There's some things that I will not eat generic brand. I want the real thing. I work every day, so that's what I want. That's what I buy. And even if you bought it for me, I know the difference between a generic, I'm just using that example, generic and brand name. And so the lungs, because the lungs aren't accustomed to 100% oxygen, even though the nitrogen is there, the lungs recognize it as a support system. Okay? And when we give too much oxygen, that 100% oxygen will wash out all the nitrogen. And the alveoli are not accustomed to that, and the alveoli will no longer respond. So the alveoli will begin to shut down and close. So we still got good blood flow coming through the capillaries. That's the perfusion. But now we don't have any ventilation. And that's called VQ mismatching. And in this case, this VQ mismatching is called a shunt. What does a shunt do? Okay, here it is. Capillary perfusion is available because the capillaries are good. However, due to the lung damage, ventilation has been limited because alveoli didn't receive the air supply, meaning the alveoli have closed. Okay, so there's no ventilation. I got blood flow around the capillaries, but I don't have any oxygen available. Now you say, well, you're giving 100% oxygen. Yeah, but you got to remember, in order for the oxygen to get into the blood, gas exchange has to occur. And gas exchange is not occurring. Does that make sense? All right. So what happens? You got capillaries flowing through the lungs, but it didn't pick up oxygen. And it returned to the left side of the heart. Venous blood returns to the left side of the heart full of CO2 and not oxygen. And then what happens? When this so-called arterial blood full of CO2 gets to the tissues, what happens to the tissues? They're deprived.
Start to die.
So we, as wonderful as we are as respiratory therapists, we're giving all this 100% oxygen. Now, I'm not saying if a patient needs 100%, you give it to them. My whole point is we have to monitor patients and assess patients when we give them 100% oxygen, because we can do more damage than good. We'll cause the alveoli to shut down and become atelectic. That's going to cause a shunt or perfusion without ventilation. Then the tissues are going to be deprived of oxygen in internal respiration. So we've defeated our purpose. We've defeated our purpose. It's just like going to the podiatrist and getting all this work done on your foot, then you go deer hunting and shoot yourself in the foot. You've defeated your purpose. And this is why you're sitting in a classroom and you understand. So if you need to decrease an FiO2, do it. How will you know? Based on blood gases, based on you monitoring the patient, based on chest x-ray, whatever. Okay. When too much oxygen is administered and we defeat our purpose, that's called refractory. I may have it in another slide. It's called refractory hypoxemia. Refractory. Is it there?
Yes, it's on page 5.
Okay. We've given too much oxygen, but we're steadily decreasing the PaO2, and consequently, it's going to eventually decrease the SaO2. You know what that means? We don't know what we're doing. Too much oxygen causes refractory hypoxemia. That means we don't know what we're doing. We gave it for one reason, but it had the opposite effect. Does that make sense? Does everybody understand what I'm saying? Yes.
That's why we do the combined, systems in critical patients where they have the compressed, air coming in along with the oxygen. So is that?
No.
No? Okay.
No. You need to give me a little bit more detail for me to answer that question.
Well, I noticed on the neonatal.
We're not talking about babies.
No, I know, but I'm just saying, but they have the combined air, and I've seen it on some of the other the higher.
You got to give me more information in order for me to answer that question. I can't tell you that. If that's the case, you just don't give them 100% oxygen. You just put them on a low gas flow system. So what you're asking me, I hear you, but I can't answer you specifically because you're not giving me enough information. I don't want to give you all any wrong information. And I don't know all the answers, but if I don't know it, I have some people that do know it. Okay? Yes.
I used to have a bar when I'd be really hungover. My buddy that was a Warren emergency.
He's going somewhere with this people. We got to listen. So what?
I would be in the bar and I'd be all hungover the next morning doing my rounds, whatever. I mean, my buddy that drove the ambulance would stop by and he'd give me oxygen,
Mhm.
and that would pep me up, get rid of my hangover.
Well, you needed it then.
Why would it, why would it get rid of the,
I don't want to answer that.
sorry, I didn't mean to take it off.
No, no, no,
topic, so I
no,
can
no,
think
no.
about it.
I'll answer it, but I'd rather tell you one-on-one why.
Okay.
Okay. Yes.
I was thinking, isn't there part of the reason you have a hangover is there's a difference when you drink causes your blood vessels to dilate and in the morning they constrict?
That's part of it. Yeah, that's part of it. But I was going to allude to continual drinking, what it do.
Oh.
So I'll answer it. All right, any other questions? So you understand that giving too much oxygen is not good. Now, I'm not saying deprive the patient, but you don't want to get to this point where we cause VQ mismatching. What is a shunt? A shunt is perfusion without the ventilation, and it's unequal. So that's why it's called a VQ mismatch. External respiration is not adequately occurring in the alveolar capillary bed membrane. So we're giving all this wonderful 100% oxygen, and we're causing refractory hypoxemia. Re means again. Fractory means that PO2 or the FiO2 is too low, hypoxemia. So we've caused the low FiO2 and a low PO2 from giving too much oxygen. We as therapists, you do not want to do this. Shame on you. I don't care what a physician writes. Don't do it if you know what's happening. And you need to be able to explain to the physician. That's why I'm telling you people, and again, I'm not trying to frighten you, but you're patient advocates.
Yes.
In respiratory care, you speak for your patient. And you need to be able to explain to any physician why you don't want to do what you don't want to do. And so Kathy Miller would recommend that you know your medical director. I had Mondra then, back then. He had a pager. He'd be on the golf course. If Kathy Miller paged him, he'd answer me. I had a rapport with my medical director. And if I didn't understand something, he would explain it to me. Had an apneic patient, they want to put him on SIMV. I wouldn't do it. I wouldn't back off. And I called my medical director. He called the intensivist. Then they weren't intensivists, but he called a physician and he said, no, she shouldn't do it. And he wrote the order. Then I did it. Why am I going to put a patient in a weaning mode and they're apneic? Some things you just don't do. So you got a CO2 retainer, and the physician doesn't know, residents don't know, interns don't know, sometimes fellows don't know. They don't know, or they could be medical students. You need to be able to explain to them what you're doing or why you don't recommend what they want you to do. You gain their respect. Not that you have to prove yourself, but I may not know the rooter, right? But I know the tutor. And I know what oxygen will do to the lungs. This goes beyond, and yeah, you're going to have an exam. It goes beyond taking an exam. Do you hear me?
Yeah.
You are dealing with patient lives. That's why I stand before you, and I am the way I am, and I make no apologies. Because you're ultimately going to be dealing with patient lives. And it's so much more than taking an exam. Understand this, okay? And I'm telling you everything I'm giving you have to understand. But this is not something that you can just compartmentalize, take an exam, and lose it. We can kill patients with oxygen. And unfortunately, I've seen it happen. And I've wept for days because I knew what happened from incompetent therapists.
Are they obligated to tell the patient's family members?
Absolutely not.
How often do you think that happens?
I don't know. I don't know, but I've seen it. I've seen it. So you cannot be methodical. You cannot be one intimidated. I can't sell self-confidence to you. You cannot. You're just not a number cruncher. When you initially go to clinical, you will be task-oriented because you don't know any different. But then you've got to be able to critically think and put this stuff together. Somebody said yesterday, see the big picture. A patient is your concern, patient assessment. This is very, very important because oxygen will kill. Oxygen will kill. And some of you are saying, you know, perhaps you don't like blood gases. You don't need to be in respiratory care if you don't like. It's not about liking blood gases. And this is not personal. This is all professional. I pride myself on graduates from this program because I believe in producing fruit. And when you go out there and you graduated from Baker College and you're registered, you're a part of me. Now, I know we all make mistakes. I'm far from perfect. I'll have 2 number 17s on the exam. I'm far from perfect. I'm not exempt. But you're dealing with patient lives. And so this, people, is a sacrifice. It is a sacrifice because this is serious. And you may not be able to articulate it as such now, but you should be able to articulate this. Why oxygen is not really good. Now again, if they need it, they need it, but it's dangerous. So a high FiO2 can cause pulmonary shunting. And you now know that that's a BQ mismatch. You got perfusion with little ventilation or perfusion without any ventilation. And so you need to know what a shunt is. And so consequently, this is external respiration. And then you got venous blood returning to the left side of the heart in the cardiac output, and it's insufficient for cellular metabolism. What's another name for cellular metabolism? Internal respiration. So now you got CO2 going to the cells, and what do the cells produce? CO2.
Yep.
You defeated your purpose. Make sense? Okay. One more, and then we'll stop, and you guys can take your quiz.
All right.
Avoid O2 toxicity. Limit patient exposure to 100% oxygen less than 24 hours if possible. Avoid it. Now this, if they're on mechanical ventilation, that's something different. Because the ventilator, and it's not called a respirator, it's a ventilator. If the ventilator is ventilating them, well, sometime they'll need it. And unfortunately, depending on what's going on, you can have a patient on 100% oxygen and they're on the ventilator and the PO2 is only 38. So you know it's some big time shunting going on, right? And something's going on. But I'm talking about someone spontaneously breathing.
Low flow.
Low flow.
Okay.
You want to avoid 100%. When they need it. Give it to them. But avoid 100% over 24 hours because you may possibly cause this O2 toxicity. You'll cause some shunting. It's acceptable to decrease the FiO2 to 70% within 48 hours and decrease to 50% or less within 5 days. So what are you saying, Kathy Miller? I'm saying the lower the FiO2, the safer it is. However, we don't deprive a patient if they need it, right? So if they need it, what does that mean? We have to monitor them. We have to assess them. So we just don't put patients and walk away. Well, the doctor ordered oxygen. We have to assess our patients. We have to monitor our patients, see how well they're doing.
It almost sounds like they're being weaned.
The whole thing of any therapy that we do is to give it to them when they need it, but we want to stop it when they don't need it. We don't even want to give a beta-2 agonist to a patient if they don't need it. It'll make them shake, it'll make them tremor. Some people, it makes them nauseated. Some people throw up when they don't need a beta-2 agonist. It'll upset the stomach. Okay. So we wean them down. And when this is said, it's in the text, that means the oxygen has been effective. Whatever we administered has been effective. So we don't have to leave them on 100%. Start dropping it to 70% or lower, and then within 2 days, decrease it to 50% within 5 days. Okay, in infants, a high FiO2 will cause retinopathy, or blindness in the baby. I was teaching medical terminology. The program hadn't started, and I told my dean, I got to teach. Give me something to teach. And so I taught a couple of medical terminology courses. And I had a young lady. She was very quiet, very bubbly, but it made sense. She had, and I noticed it, but no big deal. She was in the class. She had on glasses that were very, very thick. And when I got to, I guess, the respiratory system, or got to talking about oxygen, she willingly shared with the class that she was a preemie baby. And she knew, she understood. When she was born, she didn't have enough type 2 cells, surfactant, across her alveolar capillary bed membrane, which decreases surface tension to enhance gas exchange, yes?
Yes.
She didn't have that. So she said that she was on a ventilator, and I think she was like maybe 18 or 19. I think she had just graduated from high school. And so this was, 18, 19 years ago. And she had been on a mechanical ventilator and received high amounts of oxygen. So to make a long story short, although she had these thick glasses and could see, she had been declared legally blind. And she said she was legally blind all her life, but yet she could see because she received too much oxygen when she was a baby. She shared that with us. And she also had bronchopulmonary dysplasia, because what happens is broncho airway, pulmonary lungs, what happened was from that oxygen and being intubated, it caused her airways to lose its integrity, and the cartilage and everything just widened and became dilated. So she had on very, very thick glasses, and she was legally blind, and she had a little raspy voice, and after she said it was like, a light bulb came on, and I didn't look at her that way, but she was an infant who had been on a mechanical ventilation, she said, for about 4 months. And she was here at Baker. I don't know where, I haven't seen her, but she was declared legally blind, but she could see. Yeah.
Do you think that that was as a result of too much
Yes.
oxygen? Okay,
Yeah.
so they had basically overdosed her then?
Yeah, but she needed it.
Oh.
They may have to talk to parents and say, look, and I mean, it sounds cruel when I say this, but you can live without eyes. And so she was legally blind, but nevertheless, she sat right there in the front and she could see, to what extent. And like I said, her glasses were excessively thick. And I hadn't noticed that until she said it. And then like, wow. Yeah, but so we have to be careful. Now, neonates is another world. But we can't give them all that oxygen. It will cause blindness because it goes behind the eye and it damages the, like in adults, it's called glaucoma. Hypertension in the eyes. Well, high amounts of oxygen concentration for excessive periods, probably more than 72 hours, is going to cause blindness in newborns. And physicians have to share this with parents. So like I said, if push comes to shove, you can have a healthy, and it sounds horrible, but you can have a healthy blind child. What a choice, absolutely. But this is the potential danger that oxygen can do. Any questions?
What you said about there was no gas exchange and oxygen was still given to the baby?
No, this is in the eye. 100% oxygen causes this in the eye. This is not shunting. This is too much oxygen going across the eye blood vessels.
What about dysplasia?
Dysplasia, what does this mean? What does this mean? Okay, and what does plasia mean? I'll take that. That's not what it means, but it's close to it. What is plasia? If you look up that term, you'll see what it is. Broncho is airway, pulmonary is the alveoli. So if you look up dysplasia, you'll see what it means. You guys need to get medical dictionaries.
Is it softening?
Huh?
Is it softening?
Very good. All right, so we got bronchopulmonary dysplasia. Remember I said the bronchi and the alveoli, they get widened, they lose their integrity. Okay, they become flaccid. They lose their tonicity. The airway have cartilage around it. Why? So when we exhale, our airways won't collapse. Oxygen will do this to a baby. It'll cause a lot of damage. So we try not to leave babies on oxygen too long for that very reason. Now, if they need it, they need it. But we have this wonderful drug called surfactant now. Beractin, Curasurf. And it replaces type 2 cell in babies until they grow enough to produce their own type 2 cell. Type 2 cell is the last type of cell that grows in a fetus.
How long has that been around for?
Forever and a day. Babies die from it.
No, like when did they start giving that medication? I guess
I would say maybe in the past 20, 25 years.
Because I was a preemie.
How old are you?
31.
Oh, okay.
And it was really serious.
Yeah. Yeah. I want to say probably past
I-
25 years.
And because I don't remember when my mom told me the whole story of what it was like after I was born, she didn't
Yeah.
say that they were able to do any of that.
Yeah, yeah, because maybe 20, 25 years. Mm-hmm.
Excuse me, Ms. Miller?
Yes.
It's cold in here, I can fix that.
You know, you all need to wear jackets when you come to this class. Dress in layers. Okay, any other questions? He really does need to leave it alone, doesn't he? Doesn't he? He really does need to leave it alone, doesn't he?
Now that
No.
it's cool in here yet.
Well, I normally
When it
don't-
was warm,
I normally don't do that,
yeah.
but it was, when I came in
He
here, it was
didn't
so-
do
it was
that.
like an oven in here this morning.
You can feel it when
The
you get out
dean
of
has
the
been
stairway,
asking me how's the temperature been in here, and it has to me been pleasant, but now that it's gotten colder, I'm going to let her know. What happens is when they built this side of the building, I don't know what they did, but it'll blow heat for maybe a half an hour or maybe a half an hour, then the next hour the air comes on. And then by the time you all get ready to leave the day or when lab starts, it'll be warm in here, and then when you leave, it'll be cool. So I had just been telling her it's been fine, but now the temperature is dropping, it's not so fine. I've been aware of this, but I'm not part of maintenance. It's been my complaint ever since we've come in this lab.
Yeah, if I'd have brought in a tube of dough, I could make some.
No, you're not going to touch anything. This is maintenance responsibility. Yes, sir. Yes, ma'am. Oh, okay. Any other questions? Okay, we're going to stop right here.